in the, sorry, okay, in your Osce's. Okay, so let's see what are the things that we will try to look at it. Okay, so if you have a baby with a, if you have a situation in your unit, uh, you found this blood spillage. My screen is visible, Aparna. There is no problem. No?
Yes, 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 it's
Okay.
visible.
So how do you manage a blood spill? At least 3 points or three things that you need to keep it ready for any blood spillage. Anyone wants to answer? कैसे करेंगे आप लोग ये? Chart we have to see.
Yeah, usually they answer in the chat, in the comments,
Okay,
but
sure.
I think this was a googly, so there are
Okay,
they are
but
taking more.
yeah, that's good only. I think we'll see. Uh, these things are more common, and then everyone should also know about it. So I thought we'll keep it. Okay, I think few of you have answered it. Isolate the area and hypochlorite solution. I think that's good. So all the units should have these blood spill kit items. Even people previously used to keep the mercury spill kit also, but nowadays the mercury is not, mercury thermometers are not there. So at least a bottle with a water and then sodium hypochlorite solution, that is 0.5% hypochlorite solution, you should have it. And you should have the facility for the PPE, that is the cap and mask, and even a non-sterile gloves also do work here. And a old cloth pieces to soak that blood which is spilled there, and then you can pour your hypochlorite solution and then clean it off. Okay, so these are the things that you need to keep it ready wherever there is a spillage, and then you have to do away with the things. Okay, so somebody has really nicely pointed out that we need to isolate that area so that no one will put a put a finger or anything on the same thing. Okay, okay, so this is the first thing. Yeah, I think Sophia, can you mute yourself, Sophia? Okay, so second one is that can you people interpret this image, and what are the things that we need to do on the ultrasound to monitor? Few things on the prevention and the management. I think this everyone will try to answer. Okay. Okay, many of you are attempting, but see, when you have this type of picture, you should tell about it is a post-hemorrhagic ventricular dilatation or a post-hemorrhagic hydrocephalus. Simple hydrocephalus doesn't have a meaning here. Okay, because you can see the hemorrhage here and then you have the dilatation here. Okay, so it's a post-hemorrhagic dilatation or post-hemorrhagic hydrocephalus of infancy, whatever thing that you can look at it, that is important. Okay, so these are the three indices people will try to look at it. One is the ventricular index, second one is your anterior horn width, and third one is your thalamo-occipital diameter. These are the three consistently used parameters based upon which you can decide about the management. I'm hoping that all of you know about prevention aspect from the antenatal to postnatal. Okay, so because these babies are having pressure passive circulation, postnatally fluctuation in the blood pressures, and then no boluses, very fast boluses and hypertonic solutions, and sugars, other autoregulations which depend on oxygen level, CO2 level, and the acid base imbalance, and also on the sugar level of the baby. All these things are very important while you are monitoring the things. And yes, DSC and your head in the neutral position. These are also very important while you are managing. And also antenatal steroids also have been shown to have almost 40% reduction, 40 to 50% reduction in the IVH. Okay, these are the important things. Okay, can the people tell me that what is this breastfeeding position and where is it used? I'm little rushing. Okay. Aparna, is it okay? because it's already 10:25. Any answers? Okay. So good. It's a cross cradle position. Where is it used? Okay. So yes, it's a cross cradle position, especially useful in the early period of the postpartum because it will help for the better latch. And that's the reason why in early breastfeeding, this is one of the easiest ways to attain the good latching position. As preterm and LBW infants, it is much useful. And whenever there is a latching difficulties with the mother, especially many mothers will complain to you that on one side only the baby is feeding and on that side the baby is not feeding. In those cases, I think this is a good position for the people to use. Okay. So other positions, and then you should also know about where they have to be used. Laid back position, side laying, especially side laying is used in post C-section. Laid back where you have very good very severe reflex and other things you have to look at it. Dancer hold positions are there. So all these things are very important for you to in routine practice. Also in exam also they can ask you. Okay. So this is a question on the statistics. I kept it very simple, but I wanted you people to calculate the same. So this was study was done on the efficacy of cooling in babies with asphyxia. So they have enrolled 100 neonates in each group. That is a cooling group and other control group. In cooling group, 25 babies only have died. In the control group, you have 50 babies who have died. Okay. Can you calculate the relative risk and the absolute risk reduction and the number needed to treat based on the mortality? I don't think that you need a calculator here. It's easy. Not seeing any answers. Yeah, okay. Somebody started it. Relative risk is 0.5. Absolute risk reduction is okay. I will go to the answers. At least you people should know these things. Okay. Relative risk means the mortality in the cooling group divided by mortality in the control group. So mortality was 25 by 100 there and 50 by 100 here. So 0.25 divided by 0.5 will come to 0.5 to you. Okay. So that means the relative risk is 0.5 here. Absolute risk reduction means the difference between the mortality rates which are there, the your outcome rates. Okay, that is 0.5 minus 0.25. Okay, so this is the actual absolute risk reduction that is happening with your intervention. Okay, so that is again converted into number needed to treat for any interventions or any drug or any other quality initiation care that you will use in these baby in any of the studies. That's what we will do. That is for number needed to treat, we will calculate it by 1 divided by absolute risk reduction. Okay, so that means that if you give it for the 4 neonates, that comes to 4 here. So if you give hypothermia for 4 neonates, you will be able to save one baby dying. Okay, so that's how you have to interpret it while you are interpreting any of the statistical analysis in the RCT or in the cohort studies. Okay, Yeah, this is simple question. I'm hoping that you people will answer it. So just identify the inheritance pattern and give me two examples of the same. Very good. I can see 4, 5 answers with the mitochondrial. Very good. So why you think that it is a mitochondrial? You are able to see that from the wherever the female is affected, the other siblings are getting affected. The next generation is getting affected. So you have in the second generation, males and females both are affected, but through the males it is not getting transmitted. Only when the female is affected, you are having it as a affected. Okay. So this is a mitochondrial inheritance. Okay. So So the common syndromes which we will see is that Leigh syndrome, MELAS, and the MERRF, that is a red ragged fibers with the mitochondrial encephalopathy, which is there, and Leber's hypertrophic optic neuropathy, other condition which is most commonly associated with your mitochondrial disorder. Okay, so you have a clinical picture and also an X-ray. This baby is born premature. I think this is also one of the common condition that you come across and you will be screening. What is this condition? And do you want to look at any other diagnostic markers before taking a decision? And can you tell us 2 to 3 preventive measures for the same? Scan. Okay. Okay, I can say 2, 3 people who are answering consistently, but not others. Everyone others are sleeping, or is it okay? Okay. I have given you the clue. It is not the rickets, definitely. It is a osteopenia prematurity, but nowadays it is called as a metabolic bone disease. Okay. What are the other biochemical parameters usually we will do is that for the phosphorus will be usually on the lower side. Then you can have high ALP and the PTH also will be on the higher side. Calcium usually will be in the normal or just borderline on the lower side. Okay. So there are other parameters by which you can look at is that SOS through the ultrasound. This is different uh, sound waves which you have to see and then how much it is coming back. Then people have even looked at the CT scans and other things also for the same, but usually DEXA and other things are also not too specific for these type of scans. Okay. So the main important thing is that try to introduce the both the calcium protein and the phosphorus as early as possible. That can be achieved through your early enteral feeding. So once the enteral feeding is established well, then you can to hike up the protein and also the phosphorus, because in this disorder, the metabolic bone disease, you have both the problem of mineralization and also the matrix issue. Okay. So you have both the tissue or the protein also required for the matrix formation. And then again, the mineralization will happen through the calcium and phosphate. All the things are required for these babies. So early aggressive TPN with phosphate, especially in the small babies, because this is more common in the ELBW babies rather than the bigger babies. Okay. Early aggressive TPN with phosphates also, nowadays phosphate is available, especially when you are giving for the prolonged TPN. I think this is very important. So enteral feeding will try to help you to both for the better phosphate absorption and also for the better early protein supplementation in the baby. And HMF high human milk fortifier will also try to help you for the same. Okay. Massages and other things have not shown much, marginal benefit only. It is not the benefit which the people have looked at it, but yes, you can try to look at it. Okay. So avoid the drugs that can cause these type of problems like diuretics, the postnatal steroids. These are very important. Okay. So just minor physiotherapy will try to help you to increase the bone strength. But metabolic bone disease mainly depend on the supplementation of the protein and also your phosphorus. Okay. Yeah, this is one more case for you. It's a term neonate at 6 hours of life. The baby is on 18/6 with FAO to 50%. Just what are the striking features on this X-ray? And then write 3 differential diagnoses for that. It's a term baby who is on the ventilator. Okay, you have a bilaterally white-out lung with a reticulogranular pattern and then a little smaller lung volume. Okay, it's a term neonate. Usually the RDS is not so common. If at all it is RDS is there, either it should be a surfactant B protein deficiency or it could be due to sometimes with the mothers being a IDM. Okay, that you have to tell. Second one is a severe bilateral pneumonia, especially the GBS pneumonia. Group B streptococcus pneumonia can present and mimic this type of RDS type of picture which can be there in the baby. Okay. So while you are writing, be specific on this. Pneumonia means it could be a lobar pneumonia also, but you have to write bilateral severe pneumonia. That is more important here. And TAPVC also could be a non-obstructive TAPVC. Non-obstructive TAPVC, you don't get this whiteout lung. Okay. So you will have more of a obstructed TAPVC, then only you will have the this type of lung. Another thing is that if you have uniform whiteout appearance, other thing is the pulmonary hemorrhage, okay, because that can also cause similar problem. Of course, MAS also can has this type of problem, but I have not given you the clue that this baby is born with a meconium stand like that. Yes, if there was an MSL, maybe you could have told that it is an MAS also. Okay, so this is how you can look at it. Lung abnormality with a whiteout lung, you don't usually do it. It's a alveolar proteinosis or a surfactant protein deficiency, which is more common here. In this case, bilateral pneumonia with a group B streptococci usually common, and a obstructed TAPVC is the other thing, and pulmonary hemorrhage could be one other reason. Okay, again, I'm just given you very simple X-ray, but these are the details that you have to keep it in mind while you're writing in your exam. Okay, again, one more very important and routinely done in your your units also. So you have a baby who is on the high frequency ventilator with a map of 16 and amplitude of 25 and FiO2 of 100% and the frequency at 10 Hz. You have a, and the ABG is 7.114 and a PO2 of 40 and a PaCO2 of 76. What is the interpretation of the ABG? Diagnosis on the ABG? And can you calculate the oxygenation index for this baby? Oxygenation index is very important parameter to monitor for the oxygenation status of the babies who are on the ventilator. And you will able to see the serially, if you monitor it, you will know how is the lung status of that baby, whether it is improving or deteriorating. Okay. And also it is important parameter to take up some important decisions like starting up the inhalation nitric oxide or to go for any ECMO type of support. Okay, in this case, first thing is the pH, which is on the lower side. That means that it is an acidosis. Then you will look at the CO2s, which is on the higher side. That means the respiratory component is definitely there. But you also look at the bicarb and base excess, which is there. Base excess is almost like -8 to -9. And also for 30 mmHg increase, how much is the pH that you will drop it? So around 0.2 to 0.3, okay? So you also have, because acidosis and other things, so that's the reason why you have a little mixed acidosis picture in this baby. And other thing is that you also, whenever you are rating the ABG, not only you have to comment about acidosis, you have to look at the oxygen status and also the CO2 status. In this case, it is a hypoxemia is there and hypercapnia is there. Both the things are important in this case. Okay. So, and then when you calculate the oxygenation index, so mixed acidosis with hypercapnia and hypoxia. So how do you calculate? Map into FaO2 and postductal PO2. I kept it very simple. Map only 16 and you have 40 as your postductal PO2. Okay. So it will come as oxygenation index of 40 because 1600 divided by 40 it will come. So that will be of 40. Okay. So, okay, you have this pulmonary graphic after this. So then can you people tell me that why this baby, these are the graphics of one of the babies who had acute deterioration. In the, I think the B is one baby and another baby is C. So what could be the cause in the B and what could be the cause in the C? So write it as B and C so that it's easy for me to understand for which you are answering it. Mhm. 10:40. Okay, I think people might have got exhausted. I'm not seeing the answers much. Okay, so what is happening in these babies? Okay, so important thing here is that pressure waves are good here, but you have volume and flow waves are not going inside. And in this case, you have all the three which are erratic in this picture. Okay, so in the first case, it is a completely blocked ET tube where you are able to generate the pressure very easily because the sensor is able to detect the pressure. But the flow is not there into the lungs or also into the volume is also not there. Okay, because with the lesser flow only you are able to generate the pressure because of the tube block. Okay, tubal block. But the volume you can see is the very low, just on 1 ml only. Okay, so that could be the problem. In the second case where you have the all the things are erratic, so there could be possible that there could be have been a leak. So that's the reason why you have low volume and low flow in this scalar graphics. If you look at it, and the pressure is also very erratic. So this is what happens when you have a leak in the system, especially, and or sometimes equipment failure. Okay, pneumothorax will not present like this. Okay, yeah, last one, more easier one. So what is the stage of this ROP and what is the usual criteria for screening? Stage, right? Please write the stage of this ROP. And what is the criteria for screening? Okay. So I think we'll close it here. So see, in this case, the retinal detachment appears a little differently for you. I think you're getting confused with this picture. This is how it will be looking in any of the indirect ophthalmoscopy pictures. Okay. So it's only stage 3. You have very bad dilatation of the vessels all over. Is the extra vitreoretinal fibroproliferation which is happening. Okay. No retinal detachment here. Yes. 34 to less than 34 and less than 2 kilo. All the babies have to be screened. and between 34 to 36 and more than 2 kilos with risk factors, you have to do it. The management is basically a laser and bevacizumab that you'll do. And mainstay of your prevention is judicious oxygen therapy and blood transfusion and good nutrition and other quality measures which we'll try to use it. So I think my suggestion is that now there are some terminology which has been changed. You can look at in the recent article that has come on the ROP. Okay. So this is the day for you. I think it has been 10:44. Okay. So we'll take a call now. Do we have Dr. Aparna? Rajesh sir, you are there? Please, all of you, I think a lot of huskies are there in your YouTube channel also. Please, all of you go through these things and it is okay. Okay, I think Aparna's mobile is coming as switched off. Dr. Rajesh sir, are you there? Yeah, Sarita Sadhu, okay, shall we close it? Okay, thank you.
Thank you, sir.
Thank you.
Thank
Good
you.
night.
Good night. Thank you, everyone.
Good night. All the best for the exam going students and all the best for all the fellows. Thank you.